All right, so we are going to start out. I have a blue Bontrager, so if you want to follow along, you can. If you don't have your Bontrager, it's okay. You can just take notes. We're just going to go over the basics for routine skull positioning. That way, when we transition into RadBio, you guys have a basis before we go up to the lab. All right, so I'm on page 411. I'm going to start out with AP axial projection skull. AP axial skull, also known as the Town method. Town method. You will see this performed both erect and supine, so erect or supine. If you're doing a pediatric patient, they're definitely going to be supine on the table, just for control of the head movement. Some places have sponges to immobilize the head, some places just wrap up towels, but you don't want your fingers holding anyone's skull when you're imaging the skull, right? Because you would see these. So make sure you're using something that's radiolucent if you are holding the patient down, if it's a pediatric or a geriatric patient that has loss of control of their head or motion of their neck. So towns, so what do we need to know? It's a 40 SID, hopefully you know that. 40 SID, the IR is a 10 by 12 lengthwise or portrait. So 10 by 12 lengthwise or portrait. And then we are going to use what line to position? Does anybody know? What line we're going to use? OML or IOML? Okay, good. What's the difference? 37. Good, 37 or 30. So what are we talking about here? So the OML is the what? Orbital meatal line. Orbital meatal line. So you can use your hand as kind of your guide here. Orbital meatal line. So your meatus is right here, the actual hole of the ear. Orbital line is right here. If you use the IOML, what is it called? Infraorbital. Infraorbital meatal line. So just under infraorbital meatal line. So what are we going to do with these lines? We're going to make them perpendicular to our IR. That is how we position the head. So we don't just put somebody up against the IR like this and say, ah, that looks good, we'll center about here, whatever, whatever, whatever. So we're actually going to make the line perpendicular to the IR. So if my IR was in front of me here, I'm sorry, behind me, it's a Towns, behind me. I'm going to line up the OML if the person is able. If they have loss of neck flexion and extension, maybe they got in a car accident, you can use the IOML because you would be depressing the chin less. So it would maybe look more like this as opposed to this. How many degrees of difference do you have between the orbital meatal line and the infraorbital? 7, good. Okay, you guys are tracking, you know. And then when we talk about skull, we use a lot of exit lines, right? We talk about a lot of exits when we're doing PAs. For Towns, we can see the front of the body, the anterior portion, so we talk about an entrance. Where is our CR for the Towns? 2.5 inches above the glabella. Good. 2.5 inches above the glabella. So we're going to line the person up first. I have her standing or sitting if they're a taller patient, unlike me. If they are tall, you want to sit them down because you won't have a lot of movement with your tube because you're going to do a 30 or a 37 degree tube angulation. So when you put the angle on the tube, you're going to run out of room if they're tall. You can angle down, but only so much, right? So we're going to have our person sit down. If they're taller, probably, I don't know, I would say like 5'5" or taller, you're going to have them sit if you can. Me, I would be perfectly fine standing. I'm not that tall. All right, so if they have good neck flexion, we're going to use the OML. So we'll depress the chin down. We'll just be moving it down, probably about here. We want to make this line perpendicular with the IR. We want to use a 30-degree angle if we're using the OML. So 30-degree caudal angle if we're using OML. And we're going to center 2.5 inches above the glabella. All right, point to your glabella. Where is it? Good. Point to it. Where's your glabella? Good, good, good. Okay, glabella, good. How about nasion? Point to nasion. Good, just under, right? Remember nasion associated with your actual nasal bones, not the cartilage, not the nasion here. This is the nasion, right? Everybody good? All right, so 2.5 inches above the glabella, and this is going to pass through the foramen magnum, so we're going to be able to see it. We are also going to see the occipital bone demonstrated. Breathing instructions for this one, you can say hold your breath, you can let the person breathe, it doesn't really specify. Normally on these skull positions, they will tell you suspend respiration, but remember we're not looking for any kind of air fluid level, we are just wanting the patient to decrease the motion as much as possible. So sometimes if you have somebody with Parkinson's and they're shaking, if they hold their breath, it can get worse. So I would just maybe have them breathe normal if they're kind of moving like this. But if it helps them, if you ask them to hold their breath and you feel like they're more still, do it. But you don't have to, right? No breathing instructions for this one. Questions on the Town method. So if they don't have the ability to flex the neck because they have an injury, we're going to use the IOML, perpendicular to the IR. So instead of this, it would look more like this. If we choose to use this IOML, we're going to do a 37-degree caudal angle. So it compensates for that 7 degrees of patient position. So IOML is in place of OML. So OML 30, IOML 37. Still entering in the same CR, 2.5 inches above the glabella. Remember, we're going to estimate. You guys know we don't use rulers clinically or calipers to measure, so just a complete estimation. If you haven't measured your hand, I would probably do that. We have a ruler in the lab somewhere. My juniors were using it yesterday. But you want to know your basics, how long your fingers are, what the width of your hand is, because this can be a positioning tool that nobody can take away from you, right? You can always use this when you're positioning something, 1 inch, 2 inch, 3 inch, 5 inches, whatever you want to use. Just use your hands because they can't take them away, and you don't forget them in the radiology department. Questions on Towns? Questions on Towns? All right, Towns is perform AP or PA? AP, good. AP. All right, let's pass through here. We're going to go to the next page, page 412, and talk about a lateral. You can do a left or a right lateral. Neither one is considered wrong. Sometimes they like to place the area of interest closer to the IR for better detail, better recorded detail. So if the person has a right skull fracture or injury, they might want you to do a right lateral. Some places it's going to be more like protocol specific. So we always do a left lateral skull, or we always do a right lateral skull, or on pediatric patients we do a left, on adults we do a right. Protocol specific, neither one is wrong. You're going to see the same anatomy demonstrated. So the first thing we're going to do, we're going to stay at 40 SID. We are going to change the orientation of our IR from portrait to landscape. So from portrait to landscape. So we want it longer and wider here. We want to include all of the skull here. So we want the base to the anterior portion here. Remember not to focus so much on the mandible. It's going to look like you're clipping it when you do a lateral skull. Not important. We're not imaging the mandible. We're not imaging the facial bones. We're imaging the skull. So the actual skull. So keep that in mind. It's going to be centered a little bit higher and you're going to look like you're clipping some of this. Not important. This is not the skull area. This is facial bones. All right, so where is our CR for this one? Where's our CR for this one? 2 inches superior to the EAM, or halfway between the glabella and the inion. That's kind of a weird one there. Glabella, inion here. So halfway between here. Why don't we just say 2 inches superior to the EAM, right? Which on most people is about the top of the ear attachment right here, unless you have super big ears, then that would be too much. So about 2 inches above the EAM is going to be your center point for here. They say you can collimate inside to side if you want to. It also tells you to adjust the neck flexion to align the IOML perpendicular to the front edge of the IR. So this gets so confusing. So if this was my IR and I'm performing a lateral skull, so this is how I would position somebody. If I just shot the Towns, I'm going to have them turn all the way around and face the IR and then turn their head. Why? Why wouldn't I just shoot it like this? Less OID, good. All right, so I'm going to have them face the IR and then just tilt or turn their head so that we're parallel with the board to reduce the OID. When I have them turn, if this was my IR, the line that they want perpendicular to the front edge is the IOML. So IOML, infraorbital meatal line, should be perpendicular to this line. Very confusing wording there. I don't know why they don't just say place the IOML parallel to the IR. It's the same thing. IOML perpendicular to the front edge of the IR is the same thing as IOML parallel to the IR. Makes sense? Weird wording. Weird wording. I don't know who did that. It does tell you to place the head into a true lateral position, and then we want to align the MSP parallel to the IR. So that's going to ensure we have no rotation. So mid-sagittal plane is where? Show me on your body. Where's your mid-sagittal plane? Good. Mid-sagittal plane. How about mid-coronal? Slice it in half here. Mid-coronal. Over here. Jumping jacks. Mid-sagittal plane. Mid-coronal. If you're cutting in half this way, transverse, right? Transverse. All right, questions about the lateral. Questions about the lateral. Remember, whatever side you have closest to the IR is the side that you're going to mark. So if you are facing like this, it would be a right or a left lateral? Right, correct. And this one would be a left. Good. Skull position, you gotta be careful when you have somebody face like this and then turn them. They tend to lean on the board. Remember, we don't want any tilting or rotating. So we want them in a true lateral. A true lateral. All right, so let's see. Anything else on this one we're going to talk about? I think we're good here. Questions on the lateral? Questions on the lateral? All right, so let's go PA axial. So page 413 in the blue book, we're tracking right along here. So page 413, PA axial, also known as the Caldwell. Caldwell. So we'll talk about the 15 degrees because that's pretty standard here. It gives you alternatives below the collimation factors as far as an alternative 25 to 30 or an alternative AP axial. We're just going to focus on the 15 today because that's going to be our routine positioning. When we recap in the spring for all skull positioning, we'll talk about those other two. They're not seen very often though. But a Caldwell you're going to do pretty typical. So we're going to turn our patient around now to where they're facing the IR. Which line is going to be perpendicular to the IR? OML, good. So we're going to use this line, the orbital meatal line. So we're probably going to have to depress the chin some on most patients naturally for this line right here to be perpendicular to the IR. Remember, they're facing it. This is one of those where we have an exit point because we can't see the front of the face. So where is our exit point going to be? Nasion, good, nasion. So we want to put a 15-degree caudal angle on the tube, 15-degree caudal, and then we want to exit at the nasion. Remember to get your person in position first before you center. Why? Because if I center now and then I move my patient, my exit point will change. So always position them first, get that OML perpendicular first, and then we're going to put the 15-degree angle on to exit at nasion. Okay? They talk about this being a really good position to see the orbital field here, surrounding the orbit as far as the superior and the inferior supraorbital margins. We use this one a lot when we're doing MRI clearance. Sometimes they pop one of these in here. They might do a Waters instead, depending on your radiologist and the preference. You can see the actual surrounding of the orbit on this one. If you look at figure 111 on the same page, 411, the orbital meatal line is demonstrated well and you're able to see inside the orbits. But when you do that alternative, which is right beside it, 112, that's the alternative 30-degree caudal, you can see the orbits are filled with other anatomy. So this would not be a good demonstration if you wanted to see any kind of anatomy or any kind of pathology or artifacts demonstrated within the orbital region. So that's why we stick to a 15 for our standard. Questions for this one? Questions for this one? MSP perpendicular to the IR. You can do this one prone. It's more uncomfortable. So if the person's able to stand, you want to get them erect if possible.
Is this one like your forehead and nose are touching, but not your chin?
Yes.
Okay.
Yeah, it is going to look like that. But more so this one, I think, is the next one you're thinking about, which is the PA0. All right, so turn around the page 414. Our last one for skull is PA0. PA0. So from the Caldwell, we are going to take the angle off the tube. So no more 15 degrees down. We're going to take your angle off, so where we have a horizontal beam. Again, we're gonna use the OML. So OML is gonna be perpendicular. Your patient should already be lined up. If not, adjust them slightly. But our exit point does change for this one. So where do we exit? Glabella, good. So exit out glabella. So we're gonna go up just a little bit. Remember Caldwell, 15 degrees down, exit at the nasion. We're gonna use the OML, that's perpendicular to the IR. When we do that to a PA0, we just take the angle off the tube, so we have a horizontal beam, and we exit at glabella. Still using the OML perpendicular to the IR. Oh, I'm sorry, I forgot to tell you guys the orientation. Orientation for the Caldwell is 10 by 12 lengthwise or portrait, and it stays consistent with this one. So 10 by 12 portrait or lengthwise, however you want to say it. So PA0 and the Caldwell are both lengthwise or portrait. So our only skull position where we change the orientation is going to be our lateral, because we want to include this big boy back here, your brain, your occipital bone. So we want to make sure we turn the orientation of the IR. All of the other ones are going to be portrait. PA0, so I'll tell you guys kind of my routine, what I would normally do. I would start out with my towns, then I would go lateral, then I would go PA0, and then I would go Caldwell. Whatever order you want to do it in works, whatever works for you, not a preference. But that's just how I like to do it. I like to go ahead and get my steep angle, my 30 or 37 done with the towns, do the lateral so it's straight. Since you have a horizontal beam, if you switch and go ahead and go into the PA0, you're not turning the tube again back and forth and back and forth. So shoot that PA0 to exit out glabella, and then you put an angle on your tube, go up a little bit, and you're gonna exit at nasion for your 15-degree Caldwell. Still staying consistent with that OML being perpendicular. Questions on PA0?
Can you say that rhythm of your series one more time?
Sure. I like to do the apiaxial, which is the towns. Then I like to do the lateral. Then I like to do the PA0, and then I follow it up with the PA15 or the Caldwell, whatever you want to call it. Yep. Just so you have your angles kind of consistent here. The towns is usually the hardest. Towns tips when you're positioning clinically, you don't want to clip the top of the skull. Why? Because it's a skull projection, right? So don't clip the top. So if you feel like you're running out of light a little bit, you might want to center up. Depending on the morphology of the skull, you might have to adjust your CR slightly. So remember, just like body habitus, we teach you a starting place. You might have to adjust it when you're actually positioning clinically. So you always want to get the top of the skull in the towns projection of the skull. There are other towns. I'm going to be talking about facial bone, sinuses, mandible. What else do we have? Orbits. We're going to go through all of them a little bit every week, just to kind of refresh you guys and get you skilled up for your last comps if you haven't comped these already. Nasal bones, we'll talk about that one. Zygomatic arches. Zygomatic arches. Is zygomatic arches on your comp sheet, your new one? Can somebody check for me if you have it? Because I don't want to teach it if we're not in a position for it. They pulled one off for this year, and I think it was zygomatic arches or TMJ.
Okay. Yeah, there's
No zygomatic arch? Okay. So we'll teach you that. Is there TMJ?
Yes.
Okay.
Skull, facial limbs, mandible, TJ, nasal bones, orbits, and sinuses.
So zygomatic arches are really hard to achieve anyways because we're doing tangentials. So we're just skimming because they're really thin bones, so your cheekbones are very thin. You can fracture them pretty easy, but we can see it demonstrated on a lateral skull or a PA skull, PA0, 15. So we don't necessarily have to skim the actual zygomatic arch. What we used to do is do an SMV where you have the person tilt all the way back. You go in through here and you skim both of these each. So you center on the right one first and then you center on the left one, or the left and then the right. So 2 pictures to compare the two. I don't see it done a lot, so I thought they would pull it. I'm surprised they didn't pull TMJ either. Has anybody done TMJ? Yeah, so I see that going next, TMJ. And they also pulled Reese method off of your registry. So Reese method for the orbits. Has anybody done a Reese? Nope. All right, it's kind of where you look in like a lookout. You put the eye just like this. So cheek, chin, and nose is kind of what they position for the IR. You will still be performing it clinically, but they did pull it off the registry. Just a orbit projection specific. All right, questions on skull routine. Towns, PA0, Caldwell, or lateral. All right, hopefully you feel better now that we talked about it a little bit, and we're gonna break up into lab groups in about 20-ish minutes, and we're gonna position it. So I'll demonstrate it, you can ask questions, you can practice if you want to within your time, and hopefully that'll give you a little bit more of a basis. Bontrager from here out, if you wanna bring it, you can. I would say as far as your skills. You know your skills, you know how comfortable you are. You've technically already had the skull positioning class. If you have done a ton of skulls clinically and you feel comfortable with it, don't bring your Bontrager. If you feel lost or you don't know the material, I would probably bring your Bontrager for every class going forward to the end, because we'll do some form of positioning and recap. I just wanna make sure everyone's on the same playing field. I did get a call this week from a clinical site, just asking me to do some positioning remediation. So if you're trying to comp something and you have absolutely no idea what you're doing, you know, let's talk about it so we can remediate some here. I'm available for you. You guys have an off day from clinicals. What's your off day? Mondays. Okay, I'm here on Mondays. So come and see me. Make an appointment, right? Don't just come. Make an appointment, because I'm not always here at a specific time. So if you need help, that is what I'm here for. Use me as your resource. Don't look silly in clinicals, right? So you want to up your skills. It's okay to attempt something and not be successful about it. That's what being a student is all about. You are learning. You're in a learning process. You're in a building process. You're learning how to be a good technologist and how to position. But if you need help or you're just stuck or struggling, reach out to me. And then we'll have somebody else come in on the Monday. I'll meet with you one-on-one and we can practice some remedial positioning. Not for a grade, I'm not gonna dog you or anything, I just wanna improve your skills so you can look better clinically to kind of increase your chances of getting a job one day, okay? All right, no questions on skull. All right, let's move on to a little bit of RadBio, So we're gonna be in chapter 3 today. You will know if your physics is strong or not by this chapter. So if you feel lost, you should probably recap for physics, okay? Get that old physics book out. You guys have that thicker, kind of short, tiny blue book?
Yeah.
What's it called?
So we're chapter 3.
Radiograph, yes, chapter 3. Chapter 3, radiographic introduction to physics or something like that. Hey, what book did you guys use for technique in the spring? Do you guys remember? What did you learn in technique? That's what I want to know.
It's kind of like physics, wasn't it?
Okay, it was like a physics build
No.
with your physics class?
Together.
We don't know anything.
Pretty much. You guys trying to plan for
Yeah,
this?
we learned brightness, contrast, KVP, adjustment.
Okay, so it's like you took 2 physics classes in the spring. Okay,
Not really formula so much, but.
okay. Looking at the image critique. Did you talk about image evaluation in that class?
We went up into the lab
Sort of.
one day,
Yeah.
showed pictures, we worked on like post-processing.
Okay,
That was like.
okay. Okay. I was just curious. I was looking at kind of spring semester and planning for it. Oh, something that you might want to get a hold of, which I found mine the other day when I was cleaning out my garage. I know this is super old school, so don't laugh at me. But I found it. My husband is cleaning out the garage. He bought a shed. If you so choose to buy more material to pass your registry, which I would recommend purchasing more than you need, because you only want to take it once, right? I didn't teach you your first year, so I don't know what you know, how much you learned. I know that you were online, and it's harder to learn for a lot of people, especially when you're talking about hands-on skills. So I ordered this when, I want to say like my last semester here at FSCJ. It is called Kettering National Seminars, and it's the home study. So this is like a, I don't really even know, an MP3 player or something, but it is a specific lecture. So I listened to this all the time before I took my registry. You can skip on it. It's somebody literally lecturing for 8 hours. So it's 8 hours of study time. But you're able to skip through it. They might even have like an app for your phone now on Kettering Seminar, I don't know. But this is what they sent me. So they sent me this, and they sent me a study registry book. Highly, highly recommend it. It's good information. These lectures are good. You have to teach for like 12 years before you can teach for Kettering. So these people know their stuff, okay? They're really accurate. They're good at explaining stuff. The home study, I looked it up. It's called Kettering National Seminars. And make sure you look at the one for radiologic technology because they have respiratory therapy too. But just something if you want to do in your spare time. I know, you can get bogged down with reading and just kind of tired of looking at a book, or maybe you're driving, you're taking a trip. This is a great resource. You could skip to the physics section and listen to it 5 times, and I bet you could tell me something about physics by the time you listen to it. Okay, it's really, really good. So you can skip through, but he covers all 5 sections of your registry. So he tells you, for instance, I plugged it in, I was like, does this thing still work? Really weird my kitchen yesterday. But he was talking about positioning, and the first thing he says is, I would definitely know your anatomy for positioning, right? So they like to ask specific anatomical questions regarding positioning. What part is seen in profile? What is demonstrated? Then he talks about, I would know for sure how to identify basic anatomy on a radiograph. Then he goes into subcategories. So it's really, really, really good. He kind of tells you what to steer away from, what to steer towards, what to focus on, what is not important. But like I said, there's a skip. So if you want to listen to physics for the day, or you want to listen to one specific portion in physics, I think it's a great resource. Like I said, you can't always stare at a book, especially if you're driving. So if you can plug this in on your way to clinicals or your way home, I think it would be great benefit to you.
Does it have like a thing where you can plug it in?
It has this, so I'm pretty sure you could like plug this into an auxiliary port, right, to your car. It's a headphone jack. Like I said, this is super old, so I don't even know really what it is besides an MP3 player that's stocked with it, but you can speed it up, you can turn it up, you can skip through the sections, and it pairs with a home study book. So remember I showed you guys the test specifications, right? So he gives you an actual paperback book with all of your test specifications outlined. So I think it's a really, really good tool. Yeah.
So this is one that you would go on the website and have them sent to you.
Yes.
'Cause
Yes.
I remember we were talking about it, and it was more like a seminar.
There is
Or
a
they would
seminar,
come.
and they can meet with you here. But as far as longevity and retaining information, you can't go to a seminar, every day. But I feel like if you are kind of an audible learner, or maybe you don't have a lot of time to study, but you want to be studying now for your registry, which I would recommend, especially on winter break. If you're listening to some kind of recorded lecture over and over again, it's gonna get in your brain, right? You're gonna remember specific things. I think it's $195 for the home study, which I think is a small price to pay to pass your registry once. You guys know it's like $200 to take it. So you're basically paying for 2 registries at once if you think about it, because you're paying for your home study and then you're paying for your actual examination fee, which is $200. But you wouldn't have to study again to retake it. So if you feel like you need some extra structure, that's what I would recommend. When I found it, I'm like, oh, I need to tell my students about this. Especially on winter break. After this semester, you will have covered everything in the program. So in the spring, we're gonna be reviewing. So it's not a good time to learn everything in physics in the spring, or learn everything for skull positioning in the spring. That should be a time to find your gaps of information. Something else that's really good about the seminar is they update with your registry updates. Your registry's changing. All right, so don't buy it yet. Don't buy it yet. I bet there's something on the website that says there's a pre-order available or something like that. Is there?
So I just went on the website, it says there's an updated one coming out for 2022 in January. You can pre-order in December.
No. Okay, well, if you want to reach out to somebody else from a previous class, if you know somebody who has it, that would be a good tool. I wouldn't have kept mine if I didn't go into education, so I don't know if anybody kept theirs who went to the seminar or who chose to buy the home study. So I guess wait until January to buy it, because your registry is changing and it's specific. But if you can find a used one, I mean, it's not gonna hurt. You can skip over anything that's not covered, so for film or something specific like that. There's only a few minor changes to the registry though, as far as from 2017 to 2022. There's only a few minor changes, and you can actually see the corrections on the website. So they'll draw like a red line through it for you're not covering it for the next year. But only a few corrections. So if you feel like you need to learn all of Physics 1 over again, I would probably still invest in it. Just saying. I think it's a really good resource though, and we'll stop at that. My goal is, of course, that you wouldn't have to purchase any other resources, but I'm only teaching you 2 classes in this program, so I don't know what you've learned, and you guys have been online, and I know that's a struggle. I know when I had my first class graduate at Kaiser, we had to spend a lot of extra time tutoring for the ones who started online during the pandemic. So, it was like midway through. They started the August before last. So it's a 16-month program there, and the students that took most of their classes online were really, really struggling. So if you feel like, you just weren't in a good environment to learn, or you weren't studying enough, or you didn't retain the information, or you just don't know it, start reviewing it now so you're not overwhelming yourself in the spring, right? All right, so let's talk about RadBio, chapter 3. I'm in the white book today, remember, they sent me one. But it's not quite as nice as you guys. It's kind of like paper, just paper, not cardstock or anything. So my pages are kind of flimsy, but I guess I shouldn't complain. At least I have one and it was free. All right, so page 38. Page 38. So we first talk about KVP and mass, which are our 2 exposure factors. So what is another name that we could say for KVP? Just anything. Penetration, good. What's another one? Power, good. Power or voltage. We can associate it. Power or voltage. Penetration. What about quantity versus quality? Which one is KVP? Quality. Quality. So the quality of the image, KVP, quality of the image. Your quantity is mass, remember? Mass is your quantity, so the number of electrons. The number of electrons. But the quality is controlled by the KVP. What is a factor for your image that is contributed to KVP? Contrast, good. So increase your contrast increase your KVP, and what happens to your contrast? Increase your KVP, what happens to your contrast? Decrease. So they're alternatively or inversely related. Inversely related. So if you want increased contrast, do you have lots of shades of gray or black and white? Lots of shades of gray or black and white when you have higher contrast? Black and white. Black and white. Higher contrast, black and white. Because there's a higher contrast between the 2 shades. All right, so high contrast, black and white. So what does that mean? High or low KVP if you have a black and white image? Low KVP. Low KVP. So think black and white, think bone x-rays like extremities. I always like to think about hands and feet. So you want just a black and white contrast, right? We don't want a bunch of soft tissue. Think about your technique. What's a KVP technique for a hand? A range. What is it? 55. So we all agree that that's a pretty low KVP, right? Low KVP, high contrast, black and white. All we want to see in the hands are the bone and the skin, right? The bone and the skin, bone and soft tissue. We don't need to see any other organs. All right, let's talk about chest x-ray. What's a KVP range? 110, somewhere around in there, 110 to 120. All right, so that is a high or a low KVP? High, I agree, high, right? High. So 120, 110, high KVP. So what is that going to do to our contrast? Decrease it, inversely related. Decrease it. So what does that mean for our shades of gray or black and white? Are we going to have black and white or lots of shades? Lots of shades, good. So lots of shades of gray, which is what we want on a chest x-ray, right? So chest x-rays, we want to see more than just bone and soft tissue. We want to see organs, we want to see lungs, we want to see heart, we want to see air-filled lungs, we want to see air-filled trachea. We want to see clavicles, we want to see vessels, which is the demonstration of the carina. We want to see the hilar region. We want to see the bifurcation of the trachea. So there's a lot of different things that we want to see in a chest x-ray. So that's why we use a high KVP because we want a lot of different shades of gray, also known as a what scale of contrast? Lots of shades. Long, good. So lots of terms for refresher here. A long scale of contrast, that's how I would associate a description. A long scale of contrast when we talk about low contrast. Low contrast. So high contrast, black and white, associated with extremities, low KVP. Low contrast, lots of shades of gray. It's long. It takes us a long time to count all of the grays associated with it. Associated with a high KVP range. Obviously, your black and white is what scale for contrast? Short. Because we only have like two colors, right? Black and white. So describe the contrast of this image. Short scale, black and white. Short, there's only two colors. Long scale, lots of shades of gray, high KVP. So remember, it's an inverse relationship that we're talking about here. Inverse relationship. I kind of went ahead here. Hold on, let me find out where we're actually tracking here. All right, so KVP, we know that KVP is the peak, not the mean energy, right? It's the peak, so the highest amount of energy, kilovoltage peak, the highest energy level of photons in the X-ray beam, equal to the highest voltage established across the X-ray tube. So what is a property of X-ray that describes many different energies within one beam? I'm looking for one of the 12 properties of X-rays. Heterogeneous beam. Heterogeneous beam. Write it down if you don't know it. So what is a term that correlates with the with kilovoltage or not peak, but kiloelectron volts being different within the X-ray beam? So we know that the KVP is the highest amount of energy, but the beam has different energies, right? It's polyenergetic, so it has many energies. The KVP is just the highest possible. So the ability to have different ranges or different energies in one beam of an X-ray is called heterogeneous beam. So X-rays are heterogeneous, meaning they have many different energies. Just a basic property that you might see written on some kind of mock or exam in the future. So the thing with this is you guys are going to have to learn a lot of different terms that mean the same thing, right? So we have like 5 different terms for things that are very similar. So associate all of these terms together. Just like I said for contrast, I could say, is it a short scale? Is it a long scale? Is it high contrast? Is it low contrast? Is it high KVP or low KVP? What will it produce? There's a lot of different ways you could ask the question to get to the same area here. What are we looking at? Extremity. What are we looking at? Chest X-ray. So just things to think about. Associate terms together and kind of try to think about a picture. So I read a study that they did with like 100 people. They split 50 and 50 up. So they were talking to the first 50 about what they could see and remember images or describing something and you creating a mental image of it. So not actually writing it out if you're an artist. The other 50 people, they talked to you about remembering words or spelling. So the recognition and long-term memory of it was crazy. Almost all of the 50 people who developed a picture remembered. But the people who stuck to just word simulation or memorizing how to spell it or what the word actually means did not retain the information. So if you can think about it in terms of long-term memory, always try to associate it with a picture. So if you think about long-scale contrast, what do you see in your brain? Lots of different shades of gray. What is lots of different shades of gray? A chest X-ray, right? For an abdomen X-ray, still pretty high because we see a lot of different organs there. Rather than an extremity that's paired with black and white or a high contrast. All right, so MAS, that's our other contributing factor. This is milliamperage per second. This is the production of electron tube current and the amount of time in seconds that the X-ray tube is activated. So remember, we're controlling the time with the MAS. And the key factor here, we associate mass with the quantity. Mass is our quantity, so our numbers. And it tells you in the little paragraph under, it says peak kilovoltage controls the quality or penetrating power of the photons. It also controls to a small degree the quantity, but we don't associate quantity with KVP. So it can affect it some, but quantity is majorly or primarily controlled by mass. So that's what we want to associate it with directly. So the product of MA, which is the tube current, and time in seconds is the main determinant of how much radiation is directed towards the patient, also directly affects the patient dose. So MAS is our factor that controls the patient dose. Important to know. Important to know. So ideally, we want to use higher KVP and lower mass. Higher KVP and lower mass. Why? Because we practice LARA. Because we only want to give the patient the amount of dose that is necessary to produce, you're welcome, a diagnostic image. So we want a diagnostic image. We don't want the image to be for nothing. All right, it also tells you the significance of X-ray absorption in biological tissue. It gives you 3 factors here. When X-rays pass through human tissue, they could interact with the atoms of biological material and be absorbed. They could also interact with atoms in the biological material and be scattered, which is what kind of interaction? Scattered. Compton, good. Compton interaction, scatter, or they can pass through without interaction, which is photoelectric absorption. Photoelectric absorption. Every time I have you guys, they're doing something back there. It's only you guys, not my juniors. All right, so if they pass through without interaction, photoelectric absorption, that is how we actually see our image. So if interaction occurs, on the next column here, if interaction occurs, electromagnetic energy is transferred from the X-rays to the atoms of the patient's biological material. We know that everything is comprised of atoms, right? There are our basic elements, our basic building blocks. It says this process is called absorption. So, and this is the amount of energy absorbed per unit mass is referred to as the absorbed dose. So anytime you see absorption, we are associating with absorbed dose. Makes sense. Absorption, absorbed dose. So what is the patient actually receiving? On page 39, it gives you a picture of a patient. There's the X-rays coming down. They're like red lasers that are killing the patient. Remember, we're not going to see X-rays. Hopefully you know that by now. And it points to 2 different lines here. If this beam was polyenergetic, which it is, meaning it has many different energies because of the KVP and because of the KEV, the 2 that they are pointing to are absorbed in the patient. Absorbed in the patient. All right, it says, however, without an, I'm sorry, I was skipping a sentence here. So we don't want a high absorbed dose. That's not our goal. We want a low one. That's why we practice the LARA. But without absorption and the differences in absorption properties, we would not produce a diagnostic image. So we have to have some kind of dose to be able to actually have a diagnostic image, right? We can't just pass through completely. Something has to be absorbed so we actually have a picture. So it talks about the production of primary radiation. What is primary radiation? Give me a little makeshift definition. Primary radiation. Primary radiation. The what? You're probably right. Comes from the tube. Primary radiation comes from the tube. Good job. Primary radiation comes from the tube. So on page 39, look at that little diagram, figure 3.2 of the actual tube. Primary radiation coming directly out of the tube. Secondary radiation, what is it?
Scatter.
Anything not happening in the tube. Primary radiation, X-ray tube production coming out of the glass window. Secondary radiation, anything after that. Anything. So scatter, any kind of a scatter from a patient, any kind of absorption, any kind of electron knocked out due to an interaction, any secondary radiation that is produced that is not coming directly out of the tube is scatter. Is scattered. So when X-ray production is happening, how much percentage-wise when we have those, well, what are our 2 tube interactions? What happens within the tube? We either have this or this. Characteristic or brims, right? So we either have characteristic or brims. characteristic within the tube. So when the x-rays are actually produced. So when you see these interactions within the tube, they're not covered in this chapter, but we can do a recap if you want to later. Your two tube interactions, characteristic, K-shell interaction, or brim straw long. They also call it brims. Brims means what? Do you know? Breaking. Breaking. So brims means breaking, not you actually break something, but you break. So we're stopping. So our electron's coming in to produce it. Here's the nucleus, I'm stopping, and I'm gonna change directions. So of the interactions that are happening in the tube, we're pushing the KVP, right? We're pushing all of those electrons across the tube to produce a high potential difference. This is how our x-rays are created. How much percentage is actually going to produce an x-ray versus heat? Less than 1%. So of all of these kilovoltage peaks that are occurring, all of the KEVs that we select to actually produce, only 1% is producing an actual x-ray. The other 99% is heat. Heat. That's why we talk about thermal emission. Thermal emission, that's another term that they use on the registry. So if they say, how much percentage of thermal emission occurs in the tube? 99%. 99% of all interactions, 99%. Versus 1% of those interactions actually producing x-rays. So it's not super efficient, right? We'll get better one day. You guys can create a new tube. I believe in you. Keep going, keep going. All right, so let's get back on track here. All right, primary. Okay, anode. Anode. So what is our anode made out of? What material? Tungsten. Tungsten, important to know, it's on page 38. Your anode is comprised of tungsten or an alloy of tungsten or rhenium, but normally it's tungsten. So that's what I would associate it with. You want to know both atomic numbers of tungsten and rhenium. What is the atomic number? How do we get it? Number of protons, good. Number of protons, remember? Number of protons. This names the element. You want to know that. If they say, what is the atomic number of tungsten? You'll know it's 74. And if they said how many protons are in the element of tungsten, it's the same thing, 74, right? Remember, atomic mass is proton plus neutron. Atomic number is named on the number of protons. And this is how we call the element. If you change the protons, you change the element. Every atom of tungsten is going to have 74 protons. If it has 73, it changes. You can see they name it differently. When we increase from 74, if we gain a proton, now we're rhenium, right? We're going up. So we gain that proton and it changes the element completely. All right, it says photons are particles associated with electromagnetic radiation that have neither mass nor electrical charge and travel at the speed of light. So photons, remember on the EM spectrum, we're talking about waves, right? EM spectrum, we're talking about waves. They have no mass. They don't weigh anything. They all move at the speed of light, whether you're an X-ray, a microwave, visible light, everything's moving at the speed of light. But if you get kind of a bundle of energy, which is a wave, right? A wave, when those waves kind of interact with each other, they call it a photon. So that's why we call it an X-ray photon. It's just another name for a small bundle of energy. Still no mass, still no weight. We're still on the EM spectrum. We're not talking particulate radiation. The other day we talked about particulate radiation, alpha and beta particles, protons and neutrons. Not the same thing. Photons are traveling on the EM spectrum. We talk about X-ray photons all the time, right? It's just another name for it. X-ray wave, X-ray beam, X-ray photon, same thing. Photon associated with a bundle of energy, still no mass, still no weight, still on the EM spectrum. So don't get thrown off by that. So it talks about where the X-ray photons exit from. So once they travel across from the cathode, from the filament, the wire that's heated very hot to travel, It creates a great potential difference when you go from no electrons to a ton of electrons, however many you're pushing based on your KVP selection. They hit the anode target. The anode target has a what charge? Positive charge, right? That's why the electrons are attracted, because of that law of interaction. They're negative and they fly over to that anode target. They hit that target and they bounce off to exit the glass envelope. So the glass envelope and the lead lines, they call it the added aluminum, on page 39, the added aluminum within the collimator, so that added aluminum, those strips of aluminum that actually collimate the beam, and the glass window serve as inherent filtration. Good term to know. Inherent filtration. Inherent filtration. What does this mean? You cannot change it. It is built in, inherent. It's built in your body. You can't get rid of it. So the glass envelope or the glass window, sometimes they call it the glass window, which is where the beam exits, and the aluminum lead strips, the aluminum and lead strips that control the collimator, those are considered inherent permanent filtration. So they filter the beam and they take out the low energy photons. Why is this important? Why do we need to take out the low energy photons that aren't actually going to produce anything?
Not imaging quality.
Good. Decreasing or increasing imaging quality. So when we harden the beam or take out some of those lower energy ones with that glass window or with the collimators, it increases our quality of image. So it takes away fog, F-O-G, fog. Write it down. It decreases your fog. You don't want fog on your image because it's just going to decrease it. Also, it decreases your patient dose. Decreases your patient dose. So the more low energy photons that you have within a beam, the more are going to be absorbed into your patient because they're not going to make it through. So all it's going to do is contribute to your dose and increase it. So low energy photons, we don't want. That's why we have permanent inherent filtration in our X-ray tube. All right, let's see, what else we need to talk about here? It talks about the energy of photons. We know that the energy, the KVP, the KEV, the peak, the voltage, the quality of the image, we select, right? You select the KVP. And the beam can have no more energy than electrons that bombard the target than you select. So if you set a KVP technique of 120, your beam will never go above 120, right? Your peak beam will never be above 120. That's why we set it. However, just because you select 120, the beam is still going to be heterogeneous, meaning having many energies within the beam, and we will have lower energies within the beam as well. It breaks it down for you there within that paragraph under the actual X-ray tube on page 39. If you want to read that at home, you can. It tells you that about 1/3 of your beam is actually what you select it to be for the KVP. So if you set 100 KVP on your actual tube, about 1/3 will actually be 100. So only 1/3 is actually the peak voltage. The others are going to be 33, so less than 1/3% of what you're actually selecting. So that's why you have a heterogeneous beam. It's the difference between the peak, your actual selection, you're selecting the KVP, which is the peak, the highest point, but the beam is heterogeneous and you're gonna lose some energy and have different energies within the beam. Read over it if you still feel confused. Then they talk about the difference between attenuation, absorption, and scatter. Absorption is what? We just talked about it. What is absorption? Say it louder, I'm sorry. Patient dose, good. Absorption, what's absorbed in the patient? Absorbed dose. All right, what is scatter? What is scatter? What is it? Secondary radiation, good. Secondary radiation, anything that passes through the patient and changes directions. Scatter is a change of direction. So if the X-ray beam is traveling this way, it interacts and goes this way. Could be considered scatter, producing secondary radiation. But the term attenuation is both of these combined. Attenuation is absorption plus scatter. Attenuation is absorption plus scatter. It says some primary X-ray photons also traverse the patient without interacting. This is called direct transmission. So this is gonna be the black, the gray, the white on the picture. Direct transmission. This is created through the act of attenuation, which is absorption. So patient dose, what the patient actually absorbs in their body, and what is scattered. It gives you a really good picture. I like it on page 40. If you follow the numbers, it says on the actual tube, primary beam, right? What's the primary beam? Anything that comes out of the tube directly, okay? Primary beam. So primary radiation, so they're tracking 4 different X-rays there. So 1, 2, 3, and 4, they labeled them there. Number 1 passes straight through the patient, right? They pass straight through. They were able to get through, no interaction occurred. Primary beam number 2, they actually interacted a little bit with the atom and scattered some. They call it a small angle scatter because it still was able to project onto the image receptor. Beam number 3 was a major scatter. So it went through the patient, it changed directions completely and scattered off, barely made it to the IR. Some of these are not actually gonna land on the IR. That's why we increase our occupational dose or your student dose. If you were to walk in the room directly after you x-ray somebody, scatter could zap you, right? We have no idea of telling what's actually interacting. We don't have a number, we can't say, out of a KVP of 100, 50 are gonna scatter, 50 are gonna be absorbed, or 2 are gonna go this way, 2 are gonna have a small angle scatter. We don't have a way of noting this. That's why we wear dosimeters, because it's going to track your dose. When you x-ray your patient, you walk in the room, there could still potentially be scatter x-rays, so that's why you may have a dose reading. Make sense? You weren't actually in fluoro procedures, but you could still have some kind of dose. And then the primary beam number 4 that they label here, it tells you that you have attenuation. You have attenuation and you have an absorbed photon. So this one doesn't actually go through the patient at all. Remember, attenuation is absorption and scatter, so that's why they label beam 3 and 4. So beam 3 goes through the patient, scatters a large range, but still makes it onto the IR, still considered attenuation and scatter. Beam number 4 goes right to the patient and is absorbed completely. So whatever the energy of that was, photoelectric absorption occurred, and now we have an image on our IR because it was not able to pass through completely. So there was no direct transmission. It stopped, it was absorbed. So that's your absorbed dose. Still gonna receive an image, still considered attenuation. Attenuation is equal to absorption plus scatter. Absorption plus scatter. If the photon is able to make it all the way through the patient, it says 2 photons emerge from the tissue and strike to the X-ray detector below it. They are known as exit or image formation photons. Good term to know. If they make it completely through the patient, they are considered X-ray or image forming photons. On the next page, it talks about a little bit more small angle scatter. This is just when there's some kind of interaction within the patient and it bends just a little. So I would refer it to beam 2, primary beam 2. And then it also talks about fog. So it interferes with the radiologist's ability to distinguish different structures in the image. So think of it like you have an added contrast. You're adding some contrast. So if you want it black and white, you selected 50 kVp, you're doing a hand x-ray, but maybe something happened to your tube and the glass window was broken. Obviously you wouldn't be using it, but hypothetically, your glass window is broken, so you have no inherent filtration there. Your beam exits, you have a lot of low energy photons exiting it. Low energy photons, not productive for our image. So it's just gonna add a layer of contrast, making it harder to read the actual image, harder to diagnose. Everybody good? Questions? Everybody alive, awake? Okay. All right, let's take a small break. Let's come back at 10:05, and I'm going to assign you guys, you're gonna link up in groups. I'm gonna let you choose your groups, and I'm going to assign you an interaction. All right, so take a 20-minute break, come back at 10:05. I'm gonna assign your group an interaction to demonstrate, and then we'll go up in the lab. All right, enjoy your break. Associate it with 2 interactions. Once you actually have X-ray, it's going to be a photon interaction, okay? So that's a good way to distinguish the two. Tube interactions, brims and characteristic K-shell, cascading effect, and then when we talk about patient interactions, we have 5 different ones, only 2 occur in X-ray. So I'm gonna let you guys teach me. All right, so group 1, are you guys ready?
Yes.
All right, I'm gonna go over here and give you kind of the center. You can either, like I said, either demonstrate it with your body or write it on the board and teach us. So go ahead, group 1 is doing coherent, right? All right, make sure you're listening. This will probably be a good review for you.
Oh,
All right, so what are
I
you?
watched the video on, remember?
And you can follow along if you want to on page 44.
So, a little background. We're electrons, Terras is the neutron. Nucleus, sorry. Cat is the photon, so it's occurring in X-ray. We're the atom of a human tissue.
Okay. Okay, so we got nucleus and proton together, and electron is orbiting,
Yep.
right? Electrons are orbiting. Remember, they're in that cloud, electron binding shells. Oh, yeah. Yep. They're in the K shell.
Those work. Okay, good. So what happened? Tell us what happened, guys.
So she was low energy, so she came over to us, and then.
What energy does this occur at?
10 keV. Yeah.
10 keV. Remember, we're not talking about kilovoltage peak, we're talking about kiloelectron volts. So 10 or less. 10 or less. Does this occur in X-ray?
Yes.
It does? Not usually. Not usually. No, because we don't use 10 keV, right? We use much higher ones. We have very, very minor interaction with this. Mainly you're gonna associate this with, anybody know? Mammography or what? Absorption, no, yes, I guess, in some ways. But mainly in mammo is where you'll see this, where you use really, really low interaction. Yes, you might have some of these occur, but these are not our main interactions. We don't associate it with X-ray. You would have to be using something like 10 or 20 kVp for this to even take place. Okay, so what happened? The photon came in, they're really low energy. I like to call this one my party girl because she just comes in and she just shakes things up and she leaves. So that's called excitation, right? So they come in, they party, they shake, and they leave. Leaving nothing, no energy, no transferring. They don't knock any electron out because they're not strong enough, okay?
Temperature goes up.
Good job, guys. What is it?
Temperature goes up.
Temperature goes up, heat's released, right? Yep, heat is released. Good, I like it, I like it. All right, next. Oh, let's talk about what the names of coherent too. Let's talk about all these names. They're on page 44. You need to know all of these for your registry. Coherent is also known as classical scattering, elastic scattering, or unmodified scattering. So coherent, classical scattering, elastic scattering, unmodified. So if it's scattering, what does that mean? It's changing directions, right? So it comes in, spins around, shakes things up, and leaves in another direction. All right, next, photoelectric absorption. Who's my photoelectric absorption? All right, teach us, guys.
So we have photoelectric absorption, which basically most important mode of interaction between X-ray photons and the atom of the patient's body, producing useful images. So basically, incoming X-ray photons come into the atom of the human, and the electron is knocked out and it returns to a photon electron.
Good, I like it. So, really good drawing here too, I'm sure you saw these in the book, but anytime you see any kind of squiggly, we know that it's a photon, okay? That is X-ray. If you see a squiggle line drawn on an atom, this is a photon. This is not happening in the tube, right? If you see it in the tube, it would be a line. That is an electron, so just know that. That might help you be able to distinguish different things too. So does this occur in X-ray? What's the energy?
Now, it says 23 to 150 kV.
Okay, so do we have this in X-ray? Yes. Yes. Why is this important? Why is photoelectric absorption important?
That's what we use. Used for me.
Absorption though?
Anybody?
Oh, okay.
Anybody in your group? I know, they kind of made you the speaker, didn't
So
they?
it's basically used for imaging.
It's used to create the image. Without photoelectric absorption effect, we have no image. If there's nothing absorbed, we have nothing on the image. So yes, we definitely do this. Do we talk about inner or outer shell? Does it give you any specifics?
It happens in the inner shell.
Good, which is also known as the
Okay.
K shell, right? This is the closest one. So the K binding energy has to be equal to or greater than the incoming electron, right?
Yes.
Right? So which is what? What is the binding energy of the K shell?
Kinetic. No, sorry.
What is the binding energy of the K shell? Does anybody know? All right, write them down. These are important. You need to know these binding energies. Why is it important that you know them? Because if the incoming electron is not higher than the actual shell, it can do nothing. Okay? So 69.5 is the binding energy of the K shell. 69.5, and it's KeV, so kilo electron volts. So not the peak, just some kind of constant maintaining energy. Anybody know binding? Let's just go over them. You probably don't know them. Binding energy for the L shell. Write it down. 12 keV. So it drops significantly. So think about it. We have K, L, M, N, right? Further away and further away from the nucleus. K is the closest. So the K shell has a really tight or strong force field. Why? Because it's an electron spinning really close to a proton. So there's a lot of binding energy. The further away you go from K to L, it drops significantly. So we go to 12. So from 69.5 to 12, this means that you have to have at least that amount of power to interact with the actual shell of the electron. So if you don't have 69.5, you ain't doing nothing to the K shell. You're just going to interact with the L shell and probably go out. So this is how our interactions are occurring. Very, very important. Let's talk about M. M is 3. 3 keV. N is 0.6. So K, 69.5. L, 12 keV. M, 3 keV. And N, 0.6 keV. I'm probably going to test you on these since you don't know them, because you need to know them in physics. Okay? Very, very important. So if a question, I can think of a registry question worded like this. You have an incoming photon that's taking place in a person's body. The KeV is equal to 60.5. Can this knock out an inner shell electron?
No.
No. This is why it's important that you know the numbers.
Well, so,
Okay.
I have a question. So the K shell is obviously an inner electron. Is the L shell is sometimes considered an inner electron?
So inner shells, yes, sometimes they do group in K and L together, but they are different. So they are spaced out more. So K shell is the closest one.
Would you call the L shell an inner electron or not?
I wouldn't say the innermost shell, no.
I know it's not the innermost, but would you call it an inner?
Sure. I would probably word it like an intermediate.
But know that when you take your registry, it's not gonna be confusing. They're going, when they say inner shell, they're probably talking about K shell, is what I would associate it with. Yeah, good question. Do you know how many electrons can be in each shell? Okay, let's write it down again.
It's like 2 in the first one and then 8 others, right?
Okay, let's write it down. So K, maximum number of electrons, 2. You can only have 2 maximum number of electrons. L, 8. 8 electrons. M, 18. N is 32. So, important to know these because if you have a registry question or a mock registry question that says an electron, a cascade effect took place. Cascade means what?
All the electrons roll downhill into the air.
Right, they're moving in, they're filling in. So the electron doesn't have to go from the N to the M, or from the M to the L, or from the L to the K. A N shell electron can jump into the K shell. It's not like a process, a road. They can jump in and hop over each other, right? They all want to be close to the nucleus because the nucleons are positive. They're composed of the protons and the neutrons. So they're all jumping in, they all want to get closer. If one gets knocked out of any of the shells, at any point a further electron can jump in, not taking the initial shell. It can jump shells, basically. So an outermost shell, an N shell could jump into a K shell. If they tell you an N shell electron jumps into a K shell place, you would then subtract that number to determine how much energy was lost or gained. Makes sense? Do we remember that? So let's take an M shell electron, 3 keV. That's the binding energy of the shell. So it has to have at least 3 keV to be in that orbit, right? Say something gets knocked out of the L shell. It knocks into the L shell, which is the binding energy, 12 keV. We would subtract it because you would need at least that much to get into there. So you would go from 3 to 12, subtract it, and you would have 9 remaining. 9 remaining. Make sense? Okay, so these electrons, they can bounce around, and why are they being knocked out or why are they being displaced? Because interactions like these are happening. So this is happening all the time when we're using X-ray.
Say that last part again, subtract the KeV.
Subtracting the KeV, depending on which one is traveling. That's why we need to know the binding energy of each shell, because if we have an M shell, which starts with 3, you have to have at least 3 keV to be traveling on the M shell. And you move to L, you have to have at least 12, you would subtract it, and remainder, you would have 9.
The 12 from what?
3.
That'll be negative.
Reverse it. You would lose that much energy to travel, because you would have to have at least that much to knock something out. Okay? All right. Let's move on. Do we need to know anything else with, I just wanted to fill you in on that if you didn't know it. Sorry, I kind of got sidetracked there. Anything else that we need to know about photoelectric? Photoelectric? So photoelectric, inner shell electron taking place, and it is absorbed. So it dislodges that inner shell. It has to be at least that amount of binding energy or larger to be able to absorb it completely. So it depends on if it's the L shell or the K shell. You would have to know the energy, but typically it is the K shell interaction. This is how we produce an image on X-ray. If we had no photoelectric absorption, we would have no image on our image receptor. Okay? Very important. All right, next. Compton.
Okay, so here on the board we have comp and scatter.
Okay.
So basically, comp and scatter is this beam, or this squiggly around would be the photon, which is X-ray. So this does happen in X-ray. And that happens in the outer shell, so the end shell. And the electron will be, when the X-ray beam hits the electron, it will kind of push it out of the rings, and this is ionization.
Good.
So this is called, the electron that gets pushed out will be called the Compton electron. And then, but while this is happening, there's also a scatter photon that gets emitted from the atom as well.
Good, which could be known as what kind of radiation? Secondary, good.
Yeah.
Secondary scatter radiation.
So when the photon comes in, the electron and the photon are both put out.
Good, so they both scatter into different directions. So you have a release of electron, which is known as the Compton electron, and then you have your scattering X-ray photon, which is how we have dose. Good,
This is it would happen at 35.
nice, nice, 35 keV. This one does take place in X-ray. It's not always a good thing, right? But we also need it to have an image. We also need it to have an image. All right, next. Pair production. Pair production.
We are pair production. Okay. So pair production is not used for diagnostic X-ray, it's way too high. So it occurs when incoming photons with an energy volt of at least 1.022 MeV, which is million electron volts, when they collide and hit the nucleus and make stuff happen. So, on the nucleus,
I'm an X-ray photon that collides with the nucleus.
I'm a positron that comes off.
Okay, good.
This is a negatron that travels until it meets an atom that is lacking.
Good.
Needs it.
I
come over here.
I'm an electron from another atom.
Okay.
And we attack each other,
Okay.
annihilate each other, energy is created,
And they produce baby photons.
Okay, good. Good. I like it. Thanks, guys. That was good. That was good. So why is it called pair production?
it creates a pair.
Right? A pair of what?
Photons, positrons.
Positrons.
Sorry.
Good. So positrons are released. So it is called pair production because it is a pair, a positron and a photon. So we have a pair production release. This takes place with millions of electron volts, not kilos. So we're not talking about thousands anymore. We're talking about millions. This does not happen in X-ray. There's no way it could. It can happen in nuclear medicine if you have really, really high doses. It can also happen in PET scans. But we do need to talk about it, so it's on your registry. Not productive to X-ray specific though, but you will have an electron-positron pair that is released. An electron-positron pair. So that's why we talk about it being pair production. And let's talk about the other one, which is photodisintegration. Photodisintegration. It's our last one.
So the photodisintegration is an interaction of high energy photons, which collides with the nucleus of an atom, absorbs all the photons' energy. The interaction causes an excess in energy, the nucleus making it unstable, which then emits a neutron from the nucleus. Basically meaning if the nucleus has too much energy, it kicks one out and it's like, I don't like you anymore.
Yes.
So then, but if it has sufficient energy, it'll keep the ones it likes and kick out two people, which are, it's not on here, but it'll be called a deuteron, which is a proton and a neutron.
Good.
It doesn't happen in X-ray. It says radiation therapy, so
Yep.
nuke med,
Yes.
and it's 10 MeV.
Good. So 10 MeV, good job, guys. Thank you for that. So all the difference between photodisintegration and pair production is what? Does anybody know?
The
The neutron, so the neutron. So when we talk about photo disintegration, think about disintegration. It is gone away, the charge is released, it's neutral. It's neutral. So that is the difference. Again, 10 MeV, millions, really, really high KeVs that we're talking about here. So we would not produce this in X-ray. Radiation therapy uses this. This happens a lot when you do rad therapy. It can be dangerous because an alpha particle is released. An alpha particle. So a neutron is an alpha particle, remember? We talked about neutrons being alpha particles, and what is a beta?
Electron.
Electron. Good, good. I like it. All right, questions on interactions? Questions on interactions? Thank you for teaching me, I appreciate it. I like not talking all the time. Something that I do want you guys to know on page 49 that we didn't discuss, other names for Compton scattering. Remember, everything has a lot of different names but means the same thing. So, did we talk about these? Compton scattering, also known as incoherent scattering, inelastic or modified scattering. Modified scattering. So we need to know all of the names for this. All of the names for this. On page 45, with photoelectric absorption, which is our main producer of X-rays, be sure to not confuse this with a tube interaction. So this cascade effects that happens when the photoelectron is released, the other electrons are going to start jumping in, creating a cascade. How do you tell the difference? Like I said already, the incoming electron versus an incoming photon. If it is an incoming electron, we're talking about in the tube, and we're talking about characteristic K-shell interaction for X-ray production. It's the same thing that happens in photoelectric absorption when we have an incoming photon, because we have X-rays now. But same thing's gonna happen. We're gonna push out the photoelectron, and the electrons are gonna cascade in to fill the vacancies of the shells. So you'll have a cascade effect. You might have some secondary radiation that's produced, or heat, depending on how many interactions you have. So same type of scenario, characteristic K-shell interaction for X-ray production. We have an incoming electron because we're trying to make X-rays happen within the tube. Similar to photoelectric absorption, which is a patient interaction. So we're interacting with someone's body, someone's atoms, and we are using a photon because we already have X-rays produced. So these interactions that we covered are interactions happening in the patient's body. That's why we cover them in radiation biology, because it's important to know how much dose and how we're affecting the body. If you guys want me to, I'll do a brief kind of recap next week of brims and characteristic if you want to as well, so we can catch up on physics a little bit. All right, so that's all I have today. That's all I have. Yes. All right. So your homework is to come to class next time with, let's do facial bones. So I want you to know all of the information for facial bones. So I want you to make a matrix essentially. So you don't have to use our matrix form up here if you don't want to. Write it down on a note card, but I want you to know the SID. I want you to know the part and the patient position. Know the CRs and the angulations, the SIDs. Let me give you the page numbers for them now, for the routines. Facial bones. Let's do facial bones first, yeah. I'm gonna give you the page numbers that I want you guys to know. For my book at least.
Would you mind just telling us the views, because I think our page numbers are different?
Sure.
If we look up like
Sure.
114.
Sure. Lateral facial bones.
419 if you have the green book. Yeah.
Should be 418. Oh, my book's blue, isn't it? Sorry.
Yeah.
Okay, so lateral facial bones. Waters, it's also known as parietal acanthion projection of the facial bones. And the Caldwell method, PA axial facial bones. Alright, so those three.
So you said SID.
So SID, IR orientation and size, it doesn't need to be portrait or landscape, 10 by 12, 8 by 10, things like that. CR, where do you need to center? Everything that is on this piece of paper and the one that I uploaded. Okay. All right, have a good day, guys.